Hello, eGPlearners, and welcome to this episode where myself and Andy are covering the latest and greatest that's been happening in general practice, including various different news stories that are going to make you a little bit concerned about, are we heading towards the end of general practice? We're not talking doom and gloom. We're talking potential reality as we continue to tech enhance your primary care and learning. Let's get cracking, shall we? Hello, eGPlearners. Welcome to this episode where myself and Andy are talking about potentially the end of general practice as we know it.
As we know it, yeah. That's what people were waiting for. Yeah, not quite over yet.
No.
Potentially as we know it. So I guess to let people know what we've got in store for you today. So we'll be talking first a little bit about some of the noises, some of the information coming out of the BMA around the upcoming contract negotiations, because that's been quite exciting. There's been a report from the King's Fund about the impact and mistakes of not investing in general practice sufficiently, or primary care sufficiently, over the last few years. A few quick news stories around the waiting times for scans, around how the Pharmacy First scheme has been doing. There's announcements of a new podcast from Gandhi. Goodness knows how Gandhi finds the time. And then, the end of general practice as we know it. So there are concerns around ICB's plans for same-day access hubs and what that means for the traditional model of general practice, and could this spell the beginning of the end for traditional general practice. There's some news about the NHS Digital Framework commissioning, which is interesting. And I think that's about it, but that's quite a lot to be.
A few extra stories in there as well, but let's get cracking, shall we? And we're going to talk about, first of all, general practice and the facts as we're talking about this. Now, this is about the stuff that's been coming out from the BMA and the GPC, and in particular, this tweet that has gone legendary in my view. And when you read this tweet in detail, it is shocking to me, the facts. And these are the facts. These are created by Dr. Katie Bramble-Stainer, obviously chair of our GPC, along with some of the information that the BMA and the GPC have been researching from Freedom of Information Acts, from all the stuff that we've got. But just to read it out for you all. So since 2015, general practice has over 1,000 practices gone, over 2,000 GPs gone, and over 6 million more patients registered on their books. This is the equivalent of 1 to 2 population every month being seen by the number of appointments. And how many appointments are we talking about? 400 million consultations per year on 7 to 8% of the NHS funding, and that's delivered by 5% of the NHS staff itself. Those are the facts. Those are monumental in my view. What do you think, Andy? Because that's the first time you've seen that, isn't it, as well?
Yeah, well, we were looking at, as we were planning the show, so really quite big, shocking numbers. I was quite shocked to think that the population of England must have gone up by 10% in the sort of 9-10 years since 2015, which sort of shocked me in its own right, to be honest. But if that's happening, obviously you need a similar increase in general practice funding in order to service those people. And half the population seen each month in primary care. I think that's what's meant by that stat. That's pretty shocking as well. As ever, when you see these figures, you always think, where has this come from? And Katie's not sort of referenced it within this tweet, but you think this must have come from the BMA's general practice data dashboard, and in fact that's right. And actually it doesn't take much searching, and we'll put the link in the show notes to find exactly where this has come from. So they've taken the general practice data dashboard, and there's been a sort of a press release and story about it. They've done a pressures analysis for general practice, and that's where all this data's come from. And actually her tweet is structured in a similar way to the information is presented here. So here's the loss of 2,000 whole-time equivalent GPs, just about 1.9 1,900 GPs essentially, and they pick all these things out. So a single full-time GP responsible for about 2,300 patients.
Wow.
It's 350 patients more than it was in 2015. So just highlights a story of increased pressure, really. And it's interesting, and obviously I think this is the BMA trying to take hold of the narrative and what do they say? I think Preeti Patel says, roll the pitch for the debate that's coming. So, prepare the pitch like in cricket, for how you want to bowl. So, so I think this, again, some quite smart moves by the BMA to get their points out. Did you have any other thoughts about the tweet or the thinking behind it, the strategy behind what's happening?
We know that the GPC are building towards their release on what the contract is, and we talked last time with our colleagues Ben and Tara about the contract itself, because obviously we literally got released a few hours before we went live on that particular episode, which is done amazingly and stuff. But in terms of, we know that the BMA and the GPC themselves have said that they don't feel that the contract offered by NHS England is fit for purpose. They're sounding like they're looking towards a referendum vote towards the end of the month. It'll be really interesting to see what happens in the next couple of weeks as we build towards that 1st of March deadline, which interestingly, myself and Andy will be going live the day before that happens. So you will absolutely want to make sure you subscribe to join us for that live episode and things. But I think it's interesting context. And I know we were going to show the contract stuff, weren't we, Andy? In terms of, so this is an article from friend of the channel, Pulse. Obviously, you're welcome to go and have a look at it and stuff as they move towards this agreement-disagreement process. But it nicely compares what the NHS England have set out and what the GPC themselves feel actually is more appropriate. So there's the government offer, 1.9%. Modest increase in ours allocations and stuff, and variety of other things like adjusting QoF and some changes with ours program. And to be honest, minor changes, but the big one is obviously not really a huge amount of funding increase for what is needed to be delivered with all that work being done. An important point that I think Katie has mentioned quite a few times, or maybe not Katie, but other people have mentioned, other parts of the healthcare system have been allowed or are in the red or in the negative. Yeah. General practice doesn't go in the negative. When general practice goes in the negative, the practice is shut because they just can't cope. But those patients are still delivered care by other practices that take on that workload. So, there are parts of the system that are getting bailouts from different parts of the systems, from ICBs and that kind of stuff, because they're felt to be too big to fail. Well, general practice, unfortunately, doesn't get that same attention, respect, consideration, whatever you want to call it, and things. And actually, despite that, it's the only part of the NHS that month on month is increasing productivity.
Yeah, as evidenced by the BMA's figures and the BMA data centre. So hats off to them for that.
Yeah.
Interesting point you make about other areas of the NHS running a deficit. And that was actually another story that ran in Pulse. And Katie Bramwell-Stainer comments were kind of running through that as well. So you can see, how they're constructing their argument. This is the mood music for the negotiations. So really, really interesting. Might be with just for people listening, just highlighting the government's offer and what the GPC are demanding. I'll just do it really, really quickly. So 1.9% increase to core funding is what offered by the government, less than the current uplift of 2.4% annually on the current 5-year settlement that ends at the end of this year in an environment where inflation is currently running at 4%, but has run at much more, and wage inflation is running much higher, so considered not sufficient to meet increasing demands. Very modest increase in R's allocation. I'll just jump down to the other R's change. There's recruitment change in the R's program, brackets nurses to be included, and I don't think we know any more information about that. There were calls for GPs to also be included in R's funding. The only real big increase in funding for general practice over the last 5 years has been the PCN budget. There's been about £1.5 billion for R's staff. You break that down by individual primary care networks, something that's about I think often £1 million, per primary care network, annually. I think, Gandhi, correct me if I'm wrong, on our staff. None of that has been permitted or allowed to be spent on actually GPs or nurses. And some people feel that that's, actually with hindsight, not appropriate. They're talking about suspension of some QoF indicators, reduction in IIF indicators, aggregating the current 8 service specifications for PCN DES into an overarching specification, whatever that means. Changes to arrangements for vaccination data recording, which sounds like a very small, well, maybe important, but quite small change to be a headline change.
Tinkerings, yeah.
Yeah, and changes in the wording of the regulations in relation to patient registration arrangements. The Armed Forces veterans offer continuity of care and electronic records, so changes to the wording of regulations. So interesting. And then the GPC demand in opposite to this is an uplift by inflation for the vaccination item service fees and certain statements of financial entitlement fees. Ring fence a proportion of the current spend for the dedicated purposes, such as GP supervisory tasks or enhanced health in care homes beds premium. So I guess they want that ring fenced. Currently, some of those things currently exist, don't they? Allowing GPs with extended roles to be recruited by ARS. That's probably the big thing that they've been pushing for some GP roles to be included in ARS, and inflation-linked core contract increases. So linking that to inflation, which is probably the biggest thing that they'd be asking for and the most costly thing that they would be asking for. And finally, I would say, as part of this, in order for the probable vote of membership later this month, in order for that to be as impactful in terms of the negotiations as possible, there's a drive and a call for people who are not currently members of the BMA to join so that they can vote in that referendum. Be interested to know from people out there actually what they think about the BMA's approach to the contract negotiations. Are you a BMA member? Are you intending to join and sort of get behind what they're doing? Interesting questions. I've rambled, Gandhi. What do you think?
No, I mean, like you say, it's really interesting. I think the inflation-linked funding increase to the core is rather an interesting perspective, because if you look at almost every other service that people use, there is always a line about, well, your mobile phone contract will increase across IPI or CPI or one of the inflation-linked indexes. General practice doesn't, and yet we're still expected to deliver the same level of service, in fact, increasing levels of service and stuff, despite those cost pressures. We're going to talk about some of those cost pressures a little bit later on, one of which is definitely going to make you a bit, hairs on end and stuff and things. But, there are sensible processes within, I think, what the GPC is asking for. I think a couple of them are, the roles being within the R's. It's the name. It doesn't quite fit. It's not an additional role. But then the extended scope part of it, so things like GPs with safeguarding responsibilities, frailty, that could work and things. I think it's a great idea. Obviously, I think the government needs to come back on with a different offer. Whether they will or they won't, we will find out in the next couple of weeks. But I think with that, our next news story is definitely a marker of where the failures have been. Wouldn't you agree, Andy?
Yeah, so this is, again, we often start with a pull story, don't we? But this is reporting on a report that's been produced by the King's Fund, another friend of the podcast as well, that looks at funding in primary care, over the past 30 years, and basically reaches the conclusion that one of the big failures in health policy has been the failure to fund general practice and primary care. So not all primary care is general practice, to fund primary care sufficiently, and that's left us in a worse position in terms of our ability to deal with the challenges facing the health of our communities in England. So rambling a little bit, but it's we've had a little sort of dive in, and I guess, Gandhi, get your reactions, but we were going to just talk to some of the main points of the report, I guess.
I think, the King's Fund are great at making these kind of reports to give you perspective and to give you the facts on what is happening. I remember a while back that they said that for every pound invested in general practice, you get 14 pounds back on the economy. I can't remember exactly where that quote came from, but that just goes to show that when you invest in primary care, the returns are compound gains that you will have in the future. And actually, what this has shown is that if funding had kept pace with inflation the way it should have been, the level of resource and support that you would get in terms of healthcare would be so much more impactful. And actually, I think we would see much better long-term condition care. We'd see much better appropriate use of acute access care. It's a no-brainer, but unfortunately, that hasn't translated through into policy, as we see time and time again.
Yeah, so we're probably preaching to the choir here in terms of this is a general practice in primary care podcast, but they highlight that whilst governments and policy and strategy always speaks to the moving towards a prevention agenda, moving care closer to patients, out of hospital and into the community. The funding and the delivery, never actually is sufficient to deliver that vision, and there's been an under investment in that vision historically, and that ought to change. Is essentially what they're driving at. It's interesting looking at their main findings. So they highlight, a lack of agreement about the vision of what people are trying to achieve, with various policy shifts and changes. Is it about cost saving? Is it about better experience for people? Is it about delivering healthier populations? It seems confused, and they're calling for a more joined up strategy. Often the focus is on visible, acute episodes of care. And that's where the focus can be. So there's currently a focus on on access, isn't there? While we talk about prevention, actually all of the or many of the most visible discussions and pushes are around access, where actually more work on prevention could deliver much more for our communities. So they're highlighting that shift, essentially. And then what next? So they're talking about all the usual things, really. Having a clear vision, joined up policies, maintaining that vision for the long term, not changing course too often. Growth in funding and a shift in funding, with more funding going into communities and primary care over time. Getting the right workforce in place, training the workforce to do the job, all very, very sensible things. It may be worth doing another episode going into detail, on the report. We'll certainly link out to it if people want to have a look at that. As ever with the King's Fund, there are good. They present their data really, really well. Just showing you a little bit about what's in it, but just going through and looking at the charts is often a really nice way to read these reports if you don't have enough time to read the narrative. So really, really good work from the King's Fund. Again there. So just drawing your attention to that. Any other thoughts, Gandhi?
No, definitely. Big shout out to the King's Fund as ever. They make some amazing reports, and we've covered a few of them in the past. Like you say, we're happy to look at reviewing this for the GP learners if you want us to, and if that's the case, do let us know in the comments. Alternately, obviously, we can focus on other things as well. But I think, like you say, it's an interesting perspective that they've taken. Sometimes these reports are things that the government take notice of, and particularly the King's Fund is one of those ones that I know that they have had an impact in healthcare policy as a result of the work. We actually covered the Times 10 Health Point plan, of which some of the members of the King's Fund also contributed to that plan as well, and you can catch that episode next week and stuff. But I think it just goes to show, if you invest in primary care, the gains are there. And it's just a shame that hasn't been the modus operandi that we've seen over the past few years, which we're going to cover in some of the news roundups that we're talking about next. So this next section, myself and Andy are just going to do a really quick roundup of some of the smaller news stories before we get to some of the bigger stuff and things. Andy, do you want to do this, or do you want me to go for it? Are we after speed, or?
Let's just go speed. I think looking at the time, and I'm really keen to get to the end of general practice as we know it, because I think that's where we might get some good comments. So there's some articles in Pulse talking about the wait for scans. I think we all have been experiencing increased waits for scans, and I feel sometimes it's not fair to highlight certain parts of the country where they're really struggling with this. I think this is Guy's and St Thomas in London, but 15-week wait for routine scans, requested through general practice, really difficult for patients and clinicians there. GP considers pharmacy first, directs patients back to general practice. I think this is something that we were all, I guess, worried about. I guess it is a new scheme and it's only just been implemented. So, I think from the 1st of February, or did it start? 1st of February. So it's still really early days, so I'm sure things can improve. What's your experience been at the Pharmacy First?
Unfortunately, a lot of the local pharmacies around me don't seem to be invested heavily in terms of being able to deliver this scheme and
Yeah,
things.
the
I think for
capacity
those,
isn't there, is it?
the capacity is just not there and things. I think one of the challenges with this as well is that, they will refer some patients back to general practice because they will say that actually they can't offer treatment. And what patients often then interpret by that is, well, if the pharmacy aren't going to offer me treatment, I'm going to go back to the practice who might give me treatment. So, it's this bouncing rather than completing that episode of care. Actually saying to patients, you don't need further treatment. The advice is always, we can't offer you treatment, but you might get a different response if you go to the
Yeah,
GP.
if you still, they're always going to end with, if you've still got concerns or worries or questions, your
Go
general
to your
practice is the
GP
right place
practice.
to go.
Yeah.
And that's never really a wrong thing to say, but it can be a bit confusing for patients, and often that means that they come back have a feeling that they've sometimes heard something different in terms of, you can get this from the general practice, but you can't get it from us. So I think that's just, again, we're just sort of highlighting some themes that we're seeing, within the news and what we're hearing. Gandhi, you were going to talk about a new podcast. I always wonder how you have the time to do everything that you do, but this is something potentially that people can get involved in. So so fire away. This sounds really exciting.
Yeah, so I was trying to think, what can we do differently for eGPlearning over the next year or so? And so I'm going to tell you about Epic. So Epic is the eGPlearning Podblast implementation consultation, which is effectively your opportunity, yes, you, the EGP learners, to join us and talk about the stuff that you are doing in general practice. So this is going to be a audio podcast version of what myself and Andy sometimes do in terms of talking through different things. So if you have had a change that you've done in your practice and you want to share with other people and stuff, I would love for you to come and join us. It's audio based, so you don't have to worry about being on camera. It's just going to be recorded audio. Absolutely support you with that. If you want to apply, it's bit.ly/EPIC Epic in capitals and apply. And that will take you to that lovely little Google form that you can see there. A few quick questions for me to sort out and stuff. And then that will help me figure out where we go from there. And this is hopefully something that's going to start shortly. I just need people to apply for it. So if you want to join in, feel free to do so. This will be going out on the socials and through the emails and stuff that I have shortly as well. But just wanted to talk about it here. In addition, myself and Andy, as ever, are ridiculously busy doing some other cool things. So I thought it'd be useful to talk about some of the other updates that we've got. Last couple of weeks, we've been talking about our PCM Plus course. Sorry, Andy, I know it chops you off, doesn't it? It's really annoying. In fact, let me get to one of the other banners that probably won't do that as much. There we go. That's better, isn't it? So PCM Plus 24 live conference. This is on the 17th of April in Nottingham. We have 8 tickets left for people to join us in person for this event. That's how booked out it is. So if you want to come and join us, you need to sign up now. That's myself, Andy, Ben, and Tara, and some other amazing people talking about what is next, because this conference is deliberately after the 1st of April. So by that point, we will know what the contract is and what general practice is being asked to deliver. Finally, a week after that, myself and Andy are doing a double header, and we're going to be basically doing GP5T7. And this is our first hybrid version. So there are still a few face-to-face tickets left. I think there's about 15 or so. So if you want to come join us for that one, alternatively, you can absolutely join on the remote aspects of it. I mentioned earlier that if you wanted to join us for some of these, then hashtag eGPlearner down in the comments now. And we will do a poll at the end, which some people have already started doing for that. In fact, I'm going to prove that to you. There's a reason I'm going to prove that to you. So let me just do this. So we've got Ritu, who I've met before, who's down in London, who's already sticking hashtag eGPlearner, Sabrina Devakumar. And I think this is the Sabrina that I met at an airport about 2 months ago. Friend from University at Leeds. Interesting meeting and stuff. Didn't expect that at all. And a few others. Madas has also put their names in the hat. So, absolutely hashtag eGPlearner, and we will do that draw at the end. I'm going to suggest we take a brief break at this point, Andy, and just go to some of the comments we've had, because we've had a fair few other comments. Idea. Yeah, so absolutely friend of the podcast and the channel and stuff, Miss Melody. Congratulations on hitting 15,000 subscribers. If you want to go check out our episode that was our journey to 15,000 subscribers, feel free to do so. We've had some other comments, which this one I'm not quite sure on, so I'm going to put this one first. Living with CES is the information for medical charities and their medical boards. I'm not quite sure what you make reference to in that. So if you do want to put that in,
yeah, just follow up. I think she needs this information available for medical charities and their medical boards. And obviously, it's out there in the public domain, so anybody can watch this. And please share our content as widely as possible. Really, we'd love for it to be shared with those people. Thank you.
Jamie Green. So Jamie's done a couple of broadcasts with me previously and stuff, particularly around GP training and stuff. And he's joining us from X or Twitter, whichever we want to call it. My surgery CQC rated as inadequate due to chasing access rather than long-term conditions. Interesting, particularly with the change in how CQC are doing their assessments and things. Lisa, massive friend of the channel and stuff over at Redmore. NHS investment would pay for itself 14 times over. There you go. She's got the quote much better than I did. And from healthcare consultancy, Carnal Farrar. So she's even got the evidence to back it up and things. Who else have we got? Steve Taylor. If you haven't seen the stuff that Steve puts out on social media, it's awesome metrics and data and things. It's good funding, isn't it? One consult in Feb meets the gateway point of £1,000, even in October, only 30. I think this is what he's making reference to, the Pharmacy First funding scheme, which makes a massive difference. It's definitely an interesting point. And Ritu comments with, do you think Pharmacy First would be more effective with less bouncing back to GPs in 2 years, as current pharma isn't training in uni and will be qualifying as independent prescribers? It may change.
I agree. Yeah, I think it needs to bed in a little bit. And we need to run with the same scheme, for a period of time and not chop and change. I also agree the funding is pretty good for the level of activity that's required to draw down the funding at the moment. I think that's just to try and get people on board, isn't it? But I agree with the point that Steve is making there.
Okay, so now we're going to talk about the big news story. Now, interestingly, this is probably the oldest news story about what we're talking about, but the end of acute care, and is this the end of general practice as we know it? Why are we talking about this? Well, about a week or so ago, one of the ICBs have released their plans for having same-day access hubs, and in order to make this happen, have mandated it as part of the contract for their local enhanced services that practice will sign up to. That's the part that was interesting, because in order for practice to get access to their enhanced services, they have to agree to sign up to these same-day hubs, which is part of the Fuller report. That big report that basically everybody's been taking attention to when it comes to delivering healthcare for general practice and stuff. Interestingly, now obviously Claire Fuller is now our primary care medical director. So, very much likely to be on the agenda for general practice. This is an ICB that's going, by the sounds of it, wholehearted into it. An interesting carrot and stick mechanism. What do you think, Andy?
I think this is a really, really interesting story for a few reasons. So first of all, it's the first place that this has happened. So we all should be watching this with bated breath to see how this turns out, because if this goes badly, then this might be both an intervention and a way of implementing it that isn't repeated. If it actually works and delivers, and hopefully they'll be, monitoring the impact, then it might be something that other ICBs, choose to do. So I think it is really worth watching this story. And I think the concerns here are in a few areas, which are, I think, one, the manner in how the change is being implemented. It's being mandated. It sounds like a number of practices aren't happy, but feel that they are being pushed, to go along with this. There are short-term concerns about the implementation of it and doing it over quite a short time scale. This starts in April, and questions around, has it been adequately trialed? Can we actually deliver this properly? And then, of course, there are longer term implications for what this means to the traditional model of general practice, which is what we were alluding to, weren't we, in terms of the end of general practice as we know it, because this takes away low complexity, same day work and runs that through a different hub away from traditional GP surgeries, which will be looking after long-term conditions and more complicated patients, where arguably the continuity that they can deliver will have more impact. But it's a it's a huge change.
Yeah.
What were your thoughts initially around this story, Gandhi?
So, as we mentioned, this is the fuller stocktake acute hub mechanism that they're talking about. And interestingly, Northwest London, which is the area that it's been done in, I know they've done some really interesting work about digital hubs and really gone wholeheartedly into that. So, do they potentially have some of the infrastructure to help with this? Maybe, because they've got some really good learning that they've done from those processes and stuff. The interesting thing about this is that it focuses on creating these acute hubs, which is, I think, a GP, some of the R's roles, social link worker, that kind of stuff, in an acute setting to deal with patients' health issues, both medical health in acute care, but also some aspects with having the SPLWs and that kind of stuff around that holistic care. So it sounds really positive in that sense. I think the issue in terms of that I have with this, and obviously we don't know the full detail. We've not been a party to the contracting mechanism stuff. This is just the information that is reported in Pulse and other mediums and stuff, is about how much engagement has happened with practices to look at this, the time frames that we're looking at, what's the interoperability with the clinical systems, which is a massive part of this and always one of the pitfalls of these kind of interoperable systems that we have. But also, if practices are being told that their additional funding through enhanced schemes is predicated on them signing up to this, and they feel that they can't because of the mechanisms of how the staffing will work, then how does that mean for the future viability of those practices? Is it being used as a stick to make that happen? But then actually, what are those practices meant to do with the staff that they already have delivering these services? Now, you could say repurpose them, but some of those roles would specifically have been designed to tackle that acute demand. Now, that's either rapid repurposization, it's a HR prospect that people probably don't really want to consider because that's having to change significantly, or it's potentially making people redundant in some situations. We don't know if that's about sharing those staff with the hubs. Again, that could be part of the mechanism. But the engagement process, it should have happened to do that. That's the part we don't know about, and that's the part that we're not sure. But
yeah, and we don't know how much engagement there was. In terms of what's being proposed, I think what they're proposing is to at PCN level, so bring together single or groups of primary care networks and have a hub located in that geography. I think they're suggesting that sort of one of the practices might house the acute hub, with the other practices then delivering more traditional, long-term care with complex patients. A little bit sketchy on the rest of the detail, really. Would that rotate around the different practices, or does one practice just become an acute hub all of a sudden? We don't, we don't know. We're just responding to the story, really. If anyone's involved, we'd be really interested to hear from you. Also, really interested in terms of what people think about this model. I've always had this has always sat a bit a bit awkwardly with me, Gandhi, this debate about kind of the acute stream versus the kind of chronic complex stream that was highlighted in the Fuller report. And actually this article there is somebody quoted within it highlighting that the Fuller stock take does not mandate anybody to do anything. It is a stock take, it is advisory. So people don't have to implement the suggestions in the Fuller stock take. But I think I've said this before, but when medical students come in, I show them a video that is, we might link to it, Royal College of General Practitioners in Australia, and it's highlighting the values of primary care, of general practice, and it shows a GP over the course of his career consulting with various members of the same family. And some of the things are, acute issues. Some of the things are really meaty things like cancer diagnosis and death and bereavement and all sorts of things. And that relationship builds through some of those quicker, lower complexity interactions, and that relationship is then leveraged to really, really good effect when something more complicated happens, when he really needs to leverage that trust that he has with that family. And so that's still showing relationship based care, which the RTGP often talks about, and I think there's a lot of value in that. I think also there's potentially a lot of efficiency, in terms of separating the streams, but I'm really not quite sure where I stand in terms of what I think we should do going forwards. But really interested to know what people think, and also you, Gandhi. What's your thoughts?
Well, the video you mentioned is by the Royal Australian College of General Practice. Amazing video. If you haven't seen it, absolutely go have a look at it and stuff and things. And like you say, it bases on the relationship-based care, which the RCGP are keen to show as a model of care moving forward. I think, like you say, those acute kind of contacts help give you the buy-in with patient in terms of that emotional and empathic connection, that continuity that then is so valuable later down the line in other episodes of care, particularly with young families as well. It's the trust that comes through with some of those things. So are we going to see the difference with that? And we can see change in that. I think it's also what happens when they're full. Well, they can just go back to the practice anyway. So how does that work? What happens if the clinics aren't staffed? Well, they'll just go back to the practice anyway. So I would love to know more detail on it. I really would. So as Andy mentioned, if there's somebody from NWL who wants to come and talk about this with us, we'd love to do, absolutely love to hear it, because it is an interesting perspective. It is something that's suggested by the stock take. Again, it's not mandated. The contracting mechanism does seem a bit harsh to me, but then again, we have seen ICBs and we have seen NHS England as well do some fairly harsh contracting mechanisms that people do not agree with, and some that people do agree with. So having the other side of the story, we would absolutely love to see that happen. I guess Andy asked the question, what do other people think? You guys are definitely jumping in on this one. Let's put it that way. So let's go through some of these. So Nat Martin, what does this mean in reality for practices? Do they have to use their funding for these acute care services? Do they have to provide staffing? My understanding is they're using ours funding and some other elements of funding, whether it's the CAPE funding or other things I don't know. Again, that'd be useful to know. Catherine Armitage says, aren't these just the Darcy clinics rebranded? To a degree, yeah. But I suspect they, like I said, they're using ours funding to support that and stuff and things. She comments again, with practices already struggling for space in inadequate buildings, how they're expecting to accommodate these hubs. Massively important question there. Estates is a real challenge, as we all know, for a lot of this kind of stuff as well. Lisa Drake, I would like to see the new mode followed by researchers to assess any impact on continuity, patient and staff satisfaction. We'd also like to see the governance model behind this. Absolutely, Lisa. Going back to the data. Steve comes in with a couple of things. Let's go for this one. Personally, feel this is a huge problem for patient care. Interesting perspective. And how often do acute problems of the presentation more complex issues which are being highlighted? So, that's that thing that I think, Andy, you were trying to allude to, that sometimes the acute ones, obviously not only give you emotional buy-in with patients, but then actually how often are they bigger, more complex things, or they're the opener to talk about bigger things. And actually, will that still work? Interestingly, Nat comes back with, she likes the model as long as it's controlled by the clinicians and not by the ICB or other managerial-led organizations. Interestingly, I think this was suggested and pushed through by one of the consultancy, I think it was McKinsey or something like that. Apologies if I got that wrong, McKinsey. Please don't sue me.
It sounds like they've got KPMG. They've got a consult. They've been name dropped. I mean, no one likes it when one of the big consulting firms is involved. Do they?
Yeah, and I have to admit, I like the hub model idea. My own network, we have an acute hub. It's by no means as diverse as what they've got. To be honest, it's the model I would love to have reached. I don't have the funding to deliver that type of model, though. So, some of this evidence I think would work. But again, the practices that I work with are not mandated. They have to have all their other funding streamlined through. I think that's the issue. It's the fact that other practice income is predicated on them signing up to this. That's the part that I think is really tricky. But I can understand from the ICB's perspective, if they're putting investment and time into this, they need to make sure that practices are going to agree to it. And the best way, unfortunately, to do that is to make it a contractual requirement.
Yeah, it's interesting. I mean, I often wonder, like many things, I wonder if what we'll actually get, if this gets rolled out more widely, is something that's a little more watered down and a little less scary, really, because if what we're getting is sort of better walk-in centres, essentially, to manage patients who choose, and I think actually patient choice will be really important in this, about, where patients choose to be seen, because if you want to say you've got a cough, but then disclose an episode of domestic violence or something, I think that's your prerogative to do that, and I wouldn't want those people being directed in the wrong place. So if patients can choose where they go, and actually this is, a better walk-in centre for people who want quicker care with less complex problems, and other people can go to their GP surgery still, which is less busy because a lot of that really rapid urgent care is handled elsewhere. That may not be a bad thing, and it may not be as scary as it sounds. Sometimes these things aren't quite what the headlines say. That wouldn't be too bad for me. But if we're actually pushing patients down a certain route that might not meet their needs, and that's when I start to have kind of issues with it, really. In some ways, I'd really empathize with Steve's view in terms of, we've had a model of delivering primary care which is really, really tried and tested, and maybe we could meet people's needs if we just funded that better in terms of how we're directing the funding. I don't know. Still got lots of questions.
So on that point, we're going to move on to the next topic, which is one definitely for our tech preference eGP learners and stuff out there. So digital pathways goes off road. So what does this mean? Well, for those who have or have not heard about digital pathways is the contracting mechanism by which NHS England, about back in August, announced they were going to invest £300 million into general practice. Huge amount of money, okay, in terms of general practice over the successive years. It was the framework for how they're going to deliver things like the online consultations and other aspects of digital related care to general practice. If people may remember, I did a stream roundabout just before Christmas that talked about the comparison of the different online consultation providers, and part of that was in preparation to support people understanding the whole concept of digital pathways that was going to come through. Why is this important now? Yet again, it's been delayed. And interestingly, this time it's been delayed, not because necessarily because NHS England and the groups around it were not ready. That there seems to have been a challenge that has come through that means that NHS England now have to address that complaint, challenge. I've forgotten the word, claim. There we are, against it. Now, we don't know who's made that challenge. I suspect it's one of the providers. Who knows? Honestly, I have no idea on this. I'm completely spitballing and guessing and stuff. But it's interesting because a lot of places are waiting to see this level of funding, because it is a significant amount of funding that is meant to be delivering the whole concept of modern general practice. So we've talked about the better purchasing framework, the cloud-based telephony and things that has happened. It was one of the other big frameworks meant to support that model of delivery for general practice, and unfortunately it's been delayed. And I think that's going to have a reasonable impact on general practice moving forward, because now a lot of ICBs don't know what to procure for the next following year in terms of services and other resources for practices to help deliver patient care. Yeah, interesting one there, isn't it?
Yeah, it's the problem with these big sort of commissioning projects, isn't it? That there's a lot of law and legal frameworks around contracts above a certain size, if I remember correctly, and things have to be done in quite the right way. And sometimes, even if they are done in the right way, they can be challenged, and that has to be investigated. So slow progress. Hopefully, we get to where we need to go. I guess with that. We've had a few more comments, Gandhi. It might be worth just bring Steve on, because he's highlighting that things which might seem simple to the patient or simple to many people might actually be something that requires more intensive management. Earache can be mastocytitis, sore throat can be an abscess, migraines. Well, a headache, there's all sorts of things that can contribute, to a headache that can be behind a headache consultation. So that's really, really interesting. And just use ARS funding for GPs. So we're hearing that from the BMA and all sorts of quarters. And Nat had also made a further comment, and I guess she's more in the hub camp. We have a hub at the local cottage hospital, started in January, loved by our practice and by our patients, which is really good feedback, isn't it? So I think it's only as these models get up and running and we see how they work that I guess we'll really understand their impact.
So on that note, I guess the question is what's happening now? Well, we've covered quite a few of the questions and comments from all of our eGP learners. We hope you've had a great engagement with this particular episode. Next time, what do you need to know about? Well, we've mentioned it already. We're going to be talking about the Times 10-point health plan as we dissect it, analyze it, evaluate it, and various other 8 to it and stuff and things. And if you want to check that episode, have a look here. Alternatively, if you want to check out the Where's My GP episode that's coming out this weekend, have a look here. It's fun. Painfully fun, but fun. Well, no, it's not fun, let's be honest. And as always, we're going to be here to help tech enhance your primary care and learning.